Hi, I'm Andrew Guyman. I'm a fourth year medical student at the University of South Dakota. I'm putting together a series of different anesthesia lectures that really just cover some of the basics of anesthesiology. I hope that this is helpful for anybody who's on their anesthesiology rotation and is wanting to learn more, or anybody who has an interest in applying into the field of anesthesiology. This can help provide some of the fundamentals so you're able to ask more insightful questions and stand out on your rotations. This first lecture that we're covering contains OR etiquette and then how to present different patients. By this point, all of us should have spent some time in the OR in our pillar 2 rotations on our general surgery rotation, but there's a few different small things that you can do, especially as an anesthesia student, that can help you stand out. I'll list 10 of them here, just small tricks that can really impress your attending, help you get better letters of recommendation or stand out on your away rotations. The first one, and these are going to seem pretty basic, but they're good to keep in mind, is knowing where the automatic door opener for the OR is. Oftentimes, you're going to be walking into an OR. The patient and the CRNA or the SRNA will be following you in there, and it's really helpful if you're able to open the door for the patient so you can be part of the team and not be a cumbersome student. So we'll just say open doors. It looks good if you're able to meet the patient in pre-op and meet the CRNA in pre-op as well. It shows that you're investing in the totality of the care of the patient, not just showing up to try to intubate. But opening the doors and then also taking the bed out of the OR once the patient is transitioned from the bed that they were in pre-op onto the operating table. The other thing that's going to be super beneficial and look really good, I always do this when I'm walking into a room, whether there's any chance that I might be asked to intubate, is to double glove on your right hand. So the reason that this is helpful is when you go to intubate, you'll scissor the mouth open with your right hand, and then you'll use the blade in your left hand and you'll place the tube in, and then you'll secure the tube, and then you'll go and grab the green bag to begin ventilating the patient. I didn't realize this. It definitely makes sense, but the CRNA or the anesthesiologist or SRNA, they would prefer not to have the patient's saliva that was now on your right hand from scissoring the mouth open to be transferred onto the green bag that you're using to ventilate. So immediately after I get that tube secured, before I go to grab the green bag to ventilate, I then take off the second glove that's on my right hand that has the patient's saliva on it, and then I still have another glove beneath it, and then I'm able to ventilate the patient. It's a small trick, but I've definitely been complimented on doing that multiple times. The third thing that I do to be helpful is or I guess maybe just to make myself more part of the anesthesia team, is to introduce myself to the CRNA. That includes the CRNA, but also the surgical nurses that are in there or the circulating nurses, any of the techs. It's helpful. Everybody appreciates it. I think it also shows that you acknowledge that you're a medical student and that the other people are in a little bit of a position of authority over you by saying, hey, I'm a medical student. I'm here with Dr. Toom. He asked if I'd come in here. I'm just here to help out in whatever way I can. It makes everybody feel more comfortable as well. After that, when you're beginning to move the patient over from the bed that they were wheeled in on, that's another time that you can be an asset to the surgical team. So helping with patient positioning. And then when the patient is sliding over from the bed that they were on in pre-op onto the operating table, they always have a gown on. And if you're on the side, like the side that the operating table is on, as they begin to slide that direction, if you grab the gown and pull that towards you and out from under the patient, that's something that's very helpful. Otherwise, it sticks to them and then they get tangled underneath it. And then it's hard to remove the gown or prep the patient for surgery. So patient positioning, and then also pull on the gown as they slide from one table to the next. You can stand out by securing the patient. So every time that a patient moves onto the operating table, they're going to be positioned, and then there's going to be straps that go over them. It's a really easy thing to take those straps and secure the patient down. You could also take the arm boards and put those in place, or the cushioning or gel material underneath the different pressure points to be helpful. The surgical nurses, in my experience, have always appreciated when I've asked, hey, how can I help you position the patient or grab an arm board or something like that? Because I think that it shows, again, you're not just there to try to intubate or try to do the cool part of this procedure, but you're there for the totality of caring for the patient. You can place SCDs, sequential compression devices, on the patient. Every patient is going to need SCDs, so placing those on there is another way that you can be helpful in almost every operation. And then one way that you can really kind of stand out to the anesthesia team is if you know how to place the vital monitors on the patient, so how to place the ECG leads, which we'll cover where to put those in our next lecture, the pulse ox, and the blood pressure cuff. And not only do those need to be connected to the patient, but they also need to be connected to the anesthesia machine. So seeing, one, how to put it on the patient, but then two, how to connect it to the machine is a good way to stand out. Asking the patient, really as soon as they transition over to the operating table, saying something like, oh man, they always make these ORs so cold. Do you want a warm blanket? That's a great way to show that you care about the patient. To stand out. You should know where the warm blanket warmers are. At Sanford, they have warm blanket like warmers that are very easily accessible within the operating rooms, and then you can grab one for the patient. Asking to pre-oxygenate the patient. So I was hesitant to do this. I felt like I didn't want to be over eager, but pre-oxygenation is a pretty rudimentary task where you just hold the mask above the patient's face. And a lot of times the CRNA who's doing that has a couple other things that they could be doing at that time. So saying, hey, do you want me to hold this here for you? I don't think that that's too invasive or too upfront, rather than maybe directly asking, can you let me intubate or something? I think that asking to pre-oxygenate tends to be pretty helpful and is welcomed most of the time. I have a student who's in the year above me, and he said one thing that he always did to stand out. I haven't done this at USD, but I'll definitely look to try to learn this skill and use it on away rotations, but is to draw up medications. So he said that for most of the cases that he would do, he would draw up two 20 milliliter syringes of propofol, a 10 milliliter syringe of succinylcholine, phenylephrine, and ephedrine. And then sometimes you'd also draw up rocuronium, lidocaine, fentanyl, things along those lines. If that's a skill that you can get down, then you can actually be helpful again to the CRNA or the resident that you're working with by drawing up these medications and labeling them. Just like eliminates one less thing that they have to do. And then another tip that he gave me to be helpful was learning how to enter medications in the chart. So when the resident or CRNA would administer a medication, he would then say, hey, do you want me to chart that for you? And he would just put it directly into the computer. Another just small helpful tip. So the next thing that I want to discuss is how to present a patient. This is something that I think is super important. I read a quote once that a student had reflected on their experience in medical school, and they said, no matter how much compassion I show to the patient that's sitting in front of me, I'm going to be evaluated on how well I communicate my findings and present this patient to my attending, which I think carries a lot of weight, because not always will your attending be in there as you interview a patient. The majority of the time, their observation of you and their perspective or evaluation on you is going to be formed when you're interacting directly with them, which certainly occurs when you're presenting a patient to them. So I think it's super important to know how to do this well. The first part of presenting a patient is researching your patient. So the night before, you'll have access to their chart and their schedule, and you can begin to research these questions. In particular is what I use when I'm looking at my patient and putting together an assessment and plan for them. If you really want to stand out, one thing that I was recommended to do on my away rotations is to get this manual. It's Jaffe's Anesthesiologist Manual of Surgical Procedures. It's a large textbook, and then the night before on an away rotation, you could text the resident or attending that you're working with and say, hey, I was just reading in Jaffe's about this surgical case that we're doing. Are we planning on using this technique or this technique? It's a really easy way to show that you're engaging in the care of a patient beyond what's just occurring in the operating room. So to get on with it, this is some of the fundamentals of the things that I would know, and I would write down. I would fill out a sheet like this. I'll provide it, the PDF for this, but I would fill this out for every patient that I was responsible for in a room. So if you're working with attending at Sanford or at Monument where they use CRNAs, I would pick room 10, and I would just say, for room 10, I'm going to know every patient that is going in room 10. it's too much if attending is overshadowing 4 rooms to know about all of the patients in all 4 rooms, but you could pick one of those rooms and learn about every patient that will be in them throughout the day. So the first thing to know is the patient name. So I write down, so Sarah Joe, we'll say that she's a 48-year-old female. And then I write down room, we'll say like 18/53. So 18 is the operating room that she's going to be in. Super important to know when you're trying to quickly make your way to the case to get there in time for the intubation. And then 53 is the pre-op room that they're going to be in. Really helpful to have down because you'll go see them in pre-op and it's really easy to forget where they are. Another thing, especially for pediatric cases, that I add on here is a weight. For peds, a lot of medications can be weight-based. So then I would, for her, maybe we say she's 70 kilograms or so. Not as crucial for adults, but certainly for peds, I like to have that there. Procedure. So for her, we'll say she's undergoing laparoscopic appendectomy. We'll say appendicitis. You could add on details, perforated appendix or something along those lines. With surgeon, we'll say Dr. Van Dyne. Time. So again, this could be a few things, but we'll say 0700. The other thing that's really helpful to know is, say it's like boarded for 90 minutes. And then moving on into, this is past medical history. So a lot of this is shorthand, so I could fit it in here in a nice condensed or concise way. But I'll explain to you what my shorthand means. So anything that has the underline on it, I want to ask the patient about directly. So C stands for cardiac. So I would say, do you have any major cardiac history? Do you have any stents placed? Have you ever had a heart attack? And the night before, when I had already gone through their chart, I would have found out that she has hypertension and hyperlipidemia. Then I'm listening to see if she adds on anything that's going to be important. Stents, she just had a heart attack, anything along those lines. Pulmonary, I'm going to say, do you have any lung problems? And I would have already seen in their chart that she has obstructive sleep apnea. That's another good one to ask about directly. Do you have sleep apnea? Some people won't just offer that. I like to ask about GI, specifically, are you nauseous right now or do you have any heartburn right now? Those could be indications that maybe you'd want to think about doing an RSI on this patient. But in her history, I didn't see anything, so I'd cross it off. Endocrine, I like to ask about that too. If they have diabetes, some people won't just offer that up. And then also there, really important for determining your ASA evaluation or ASA score for a patient is if they have significant obesity. So for this patient, we could say that they had a BMI of 55, and if so, I would write obesity, and then I would put in parentheses 55, and that's the BMI. Neuro, so if they have any sort of chronic pain, that would be very pertinent because maybe you'd need to think about using more medications post-op to manage their pain. And then our renal, if they have any renal issues. But for this patient, we'll say that they didn't have any concerns with their GI, their nervous system, or any renal concerns either. Then I would move over into the past anesthesia history. This right here, I consider electronic history. So I would have gone in their chart, I would have gone to the anesthesia tab and looked to see if there's any history of a difficult intubation, delirium, or emergence delirium, anything that would key me in on different concerns that are already marked in the chart. Problems, I'd ask, if you've had anesthesia before, did you have any problems with anesthesia? We'll say for her, she said, no, I didn't see anything in the chart that was concerning. And then family history of anesthesia. So do you have any family history of problems with anesthesia? The reason that's important is the big thing that you're looking for is malignant hyperthermia. Now, that's a big concern that you would have for any patient. And if they reported that, that would totally change your anesthetic plan. Sometimes they'll report their grandparents had emergence delirium or their mom gets nauseous when they wake up. And those are also things that can be important just to keep in mind. I would definitely ask right here in parentheses if they've had anesthesia in the past. That's probably the opening statement with what I would say. Have you had anesthesia in the past? Generally, after looking through their chart, I would already have an idea, and maybe they would report or would have seen in this patient's chart that they had a history of spine surgery. I'd like to record in this portion the most significant surgery that they've had in the past, because then that can clue into me whether that I know if they've had general anesthesia or not, if they've had exposure to volatile anesthetics or paralytics or had to be intubated. And I'll move on and I'll say, when's the last time that you ate or drank anything? And if it's been sufficiently long enough, then I'll record greater than 8 hours. I'll ask specifically if they felt nauseous after they had anesthesia in the past. Sometimes people won't report that when you ask about problems, and it's a very common problem. So I'll say, did you throw up or feel nauseous after anesthesia in the past? Here we'll say they didn't. And then generally, not with every surgery, maybe it's best practice with every surgery, but almost all the time I'll ask, if you need blood, would we be able to give it to you? Sometimes I read the room. If the patient looks really anxious, then I'll just leave that question to be asked only by the anesthesiologist. Just trying not to rock the boat. But they would say, yep, that's fine. So I'd put a check mark there. I would then move into the meds section. So I would say, okay, what medications are you on? I would have already glanced through the medication list. And then I would say, which medication specifically did you take today? A big one is metoprolol, to make sure that they did take that on the day of surgery. And other medications to be aware of would be GLP-1 agonists or SGLT2 inhibitors. So both of those GLP-1 agonists can cause delayed gastric emptying and then increase your risk for aspiration. SGLT2 inhibitors are associated with euglycemic DKA, which both of those are rare complications that could happen during anesthesia, but important things to be aware of. Under their social history, I'll ask, do you smoke, drink, or use any drugs? All of those can be pertinent to how the patient will respond to different anesthetic medications. And then I'll ask, do you have any allergies that I should be aware of? For this example, we'll say they don't smoke, drink, or use any drugs, and they have no drug allergies. I'd move on to assessing what their vitals are just from the monitor. We'll say here that they're normal. A lot of times in pre-op, they won't be hooked up to the monitor at the time that I'm seeing them. That's okay. Just roll with it. As long as they look good, you can assume in pre-op that their vitals are normal. Then in the objective section, the big two systems that I always review is going to be any cardiac studies or lung studies. So cardiac studies, that's going to be if they had an echo, and then specifically the year that they had it and what the ejection fraction or findings were, if they've had stress testing, if they've had a cath done. Lung studies could be like PFTs or a sleep study if they have sleep apnea, something along those lines. And if I see any of those in the chart, I'm going to, like I said, I'll record it here. And then I'll also make sure to record specifically the year that it was completed. For this patient, we'll say that they haven't had any cardiac or lung studies at this point. Then I'll move over into, and I would ask them about this as well and say, have you had any lung or cardiac heart studies done? Moving over into the physical exam, there's various different risk factors for difficult intubation or difficult mask ventilation. So those are things to keep in mind during the physical exam. If you're going to be performing like a spinal, then you could examine the back, see if there's any scoliosis, if they've had any previous surgeries on it, things like that. The big things that I keep track of on the physical exam. So first I just look at the face to see if there's any sort of a beard. For the mouth, I always ask, is there anything removable or loose that can come out of the mouth? I'll ask them to pronath or protrude their lower jaw. So I'll say, can you take your lower jaw and bite your upper lip just like me? And I'll demonstrate that for them. And then I'll have them open their mouth and stick out their tongue, and I'll evaluate their Mallampati score. So those are three different things that I look at with their mouth. Their Mallampati score, if they're able to extend or protrude their lower jaw, and then if there's anything removable within their mouth. Neck, there's a few different things you can look at, but the thyromental distance, that can be a predictor of difficult intubation. Also the neck circumference. So if they have a thicker neck, I've never seen anyone measure it, but if their neck circumference is greater than 40 centimeters, that's a predictor of both difficult mask ventilation and difficult intubation. And then I always listen to their heart and lungs to see if I can hear any sort of a murmur. Finally, after you complete all of this, you've kind of done your entire assessment. You can really go through almost all of this except for the physical exam the night before when you're reading through their chart, and then you're just double checking it when you visit with the patient in the morning. Finally, once I get to the plan, I would write down like the key component of the plan is going to be their ASA score. So for this patient, they're automatically going to be at least in ASA 3 because their BMI is 55. So we'll say this patient is ASA 3, and then this like symbol here means with. So I would say general anesthesia because they're undergoing laparoscopic appendectomy. Right here, pre stands for pre-op, so anything that I would want then. That's going to include laboratory studies. So if they're diabetic, maybe we'd want to make sure that we reviewed what their blood glucose was. Like other studies, so like an EKG or medication. So you can pretty much always say that you're going to give a patient Tylenol. AIR stands for airway. So how are you planning on managing their airway? Well, for this patient, since they're having a laparoscopic surgery, we'll say endotracheal tube. And then another piece you can add on to that is with, for them, I guess, for the sake of this video, we'll say with video laryngoscopy, because of their obesity, that could make them a more difficult airway. Monitors, so always standard. You're always going to have standard. But then you could also think about if you were concerned for some reason that you would want an arterial line, you could add that there. If you're running a TIVA, then maybe you'd want to add a BIS monitor. So standard monitors, plus or minus whatever else you're concerned with. This stands for access. So if you're doing a robotic case, that's a time where you'll always have 2 peripheral IVs. For this case, it's not robotic, so we'll just say 1 peripheral IV. Induction, so I would say we're planning on inducing with propofol. And if you really want to run through everything to show your knowledge, you could say inducing with propofol and then also administering fentanyl, lidocaine, ketamine for pain. And then maintaining with sevoflurane. PA stands for pain, so we're going to manage their pain. The routine that I generally have is Tylenol, ketorolac, fentanyl, ketamine. Managing post-op nausea and vomiting. If they were high risk, if they had a history for it, you maybe would have added other things such as Amend or Ranativa. But for this patient, we'll just say Zofran and Decadron. And then disposition, PACU1 versus PACU2. We'll say, well, we're sending this patient to PACU1 after surgery. PACU1 is where everybody after general anesthesia goes. PACU2 is where people after just a colonoscopy can go following their procedure. The reason I wrote all of this out, and I always do for the patients that I'm reading up on, is then when you go to present this patient, it makes it very easy. So I would then go to my attending and say, hey, I saw this patient. Can I present them? They'd say, sure. And then I would just read off everything that I have. So I would say Sarah Jo is a 48-year-old female who's undergoing a laparoscopic appendectomy for a perforated appendix with Dr. Leslie Van Dyne. She's scheduled to begin at 7 a.m. and is boarded for 90 minutes. She has a past medical history significant for hypertension, hyperlipidemia, obstructive sleep apnea, and no other major cardiac or pulmonary concerns. She is obese. She has a BMI of 55. She's had spine surgery in the past and underwent general anesthesia. I didn't see any anesthetic problems in her electronic history. She didn't report any previous problems. She has no family history of problems with anesthesia. She's been NPO for at least 8 hours. She hasn't had any problems with post-op nausea or vomiting. She's okay with receiving blood if she needs it. She took her metoprolol today. She doesn't drink, smoke, or use any drugs. We have no concerns for allergies. Her vital signs are normal. She hasn't had any cardiac or pulmonary studies completed. On physical exam, she has a face that looks amenable to mask ventilation. She doesn't have anything loose or removable in the mouth. I would say she's a Mullen-Potty grade 3. She doesn't have any risk factors for any other risk factors for difficult mask ventilation or intubation. Overall, I say that Sarah is ASA grade 3, undergoing general anesthesia. We can give her Tylenol and pre-op. We'll manage her airway with an endotracheal tube and video laryngoscopy. We'll use standard monitors alone, obtain venous access with 1 peripheral IV. We'll induce her with propofol, fentanyl, lidocaine, ketamine. We'll maintain her anesthesia with sevoflurane. Post-op, we can manage her pain with Tylenol, ketorolac, fentanyl, or ketamine. We'll manage her post-op nausea and vomiting with Zofran and Decadron, and we'll send her to PACU1 following surgery. It makes it a very easy way to present in a fluid manner. And then ultimately this whole chart that I wrote down is just 1/4 of a piece of paper. So it's this. And then you have another one here, and another one here, and another one here. So on one sheet of paper, you can record 4 patients, and I fold this up into fourths and carry it around in my pocket. That way I have a mini HMP on all the patients that I've seen. It makes it easier to engage with faculty, residents, CRNAs about the patients that I'm participating with because I have all of their information on me. I hope that this helps. Let me know if you have any questions.